So good morning all. So nice to meet you all here in this 6 a.m. club of ADRPLEXUS. So I'm also one person who has joined this 6 a.m. club along with you. So as the saying says, the early bird catches the prey. This is one of the innovative method of making you people, including me, to get up early and see the early morning world. And this is one opportunity to join with you people to discuss very, very important topics, high yield topics of NEET-PG exam. So today, as I promised in the regular class, the topic which has to be discussed and which has been expected to be discussed for sarcoidosis. So today I have got a chance to discuss sarcoidosis. To not waste much time on the regular things, I will go directly to the topic. So here today we are going to discuss only the high yield points of sarcoidosis. So sarcoidosis is also called as Besnier-Boeck-Schaumann disease. Besnier-Boeck-Schaumann disease. So sarcoidosis is, again, as we think, it's not a connective tissue disorder. Not a connective tissue disorder, rather a multi-system inflammatory process. Okay, so the exact etiology of sarcoidosis is still unknown. Okay, the exact etiology of sarcoidosis is still unknown. Okay, so if you take the female to male ratio, it is going to be at a ratio of 2:1. So again, this is going to be a female predominant disease. Okay, and this disease has bimodal age distribution. The one peak incidence occurs at 25 to 35 years of age, and the second peak incidence occurs at 45 to 65 years of age. So it has a bimodal age distribution. So the first peak at 25 to 35 years of age, and the second peak at the 45 to 65 years of age. Okay. So how this disease occurs? This disease has some trigger factors. These trigger factors activate T cells and this results in inflammation, and ultimately there is going to be formation of non-caseating granuloma. This non-caseating granuloma is going to be the hallmark of the disease of sarcoidosis. So ultimately there is going to be non-caseating granulomas. We will see how the non-caseating granulomas are being formed. Okay, so we have trigger factors. Okay, so what are the trigger factors for sarcoidosis? So the trigger factors for sarcoidosis are Borrelia infection, virus infection. So there are few viruses which are associated. The virus is going to be Epstein-Barr virus, herpes zoster virus, cytomegalovirus. and it is known to be associated with Mycobacterium tuberculosis. Mycobacterium tuberculosis. It also has association with few HLAs. HLA DQ B102, HLA DR B10403, and HLA DQ B8. Okay, DQ B8. Okay, so these are the HLAs associated with the sarcoidosis, and they also act as trigger factors, and they will result in activation of T helper cells, and this results in inflammation and non-caseating granulomas. So how this whole cascade occurs? Okay, so the sarcoidosis is going to be immune-mediated disease, as we discussed earlier. There is going to be T cell dysfunction. Along with that, there is going to be increased B cell activity. B cell activity. Okay, so this results in local immune hyperactivity and inflammation. Okay, inflammation. So what is happening here? Okay, so this results in a local immune hyperactivity and inflammation. So what is going to happen here? The macrophages are known to activate T helper cells. Okay, these T helper cells will start releasing interferon gamma. So the T helper cells are going to release interferon gamma. Okay, this interferon gamma will stimulate formation of epithelioid cells and multinucleated giant cells. Okay, multinucleated giant cells. These epithelioid cells are also known to activate or produce angiotensin converting enzyme. Okay, angiotensin converting enzyme, and this results in activation of cytokines, and further immune cells are produced. Okay, so all these factors will join together to form a mature granuloma. Mature granuloma. Okay, so what this mature granuloma contains? Okay, so this mature granuloma contains a center of macrophage and epithelioid cells. Macrophage and epithelioid cells. Okay, and it is surrounded by lymphocytes and fibroblast. This results in further fibrosis of the organs and subsequent damage to the cells. So this ultimately results in fibrosis of organs. This results in fibrosis of organs and further damage to the tissue. Okay, further damage to the tissue. So these granulomas, okay, this is called a granuloma, and this granuloma is the hallmark of sarcoidosis. So it is a non-caseating granuloma. Never forget that. It's a non-caseating granuloma. Never forget that. Okay, never forget that. Okay, so your sarcoidosis presentation can be of two types. It can be a acute presentation and a chronic presentation. Okay, so acute presentation is seen in 1/3 of patients. The chronic presentation is seen in around 2/3 of patients. 2/3 of patients. Okay, so acute presentation has a better prognosis. It has a good prognosis. This has a bad prognosis. Okay, here the acute presentation usually will have spontaneous remission. It is not so in the case of chronic diseases. The onset of disease is also a sudden onset in acute presentation, and it is going to be a gradually progressing disease with an insidious onset in chronic sarcoidosis. So these are the difference between the acute sarcoidosis and chronic sarcoidosis. So we will see individually how a patient with acute sarcoidosis will present, how a patient with chronic sarcoidosis will present. So the first one is going to be acute sarcoidosis. Acute sarcoidosis. Okay, so acute sarcoidosis is typically have a sudden onset. As I told earlier, it is going to have a sudden onset. Okay, and it remitts spontaneously within 2 years. So it remitts spontaneously within 2 years. The progression of acute to chronic is relatively rare. Okay, relatively rare. Okay, so this progression from acute to a chronic form is relatively rare. Okay, then the clinical features. We have the patient with acute sarcoidosis have constitutional symptoms like a low-grade fever, weight loss, malaise, and loss of appetite. So these patients have some kind of atypical, okay, or generalized symptoms like low-grade fever, weight loss, malaise, loss of appetite, like that kind of symptoms will be there, and usually it is unnoticed. Okay, and then they develop pulmonary symptoms. Okay, and this pulmonary symptom will be usually in the form of dry cough, shortness of breath, especially on exertion, and chest pain might be there. So these are the pulmonary symptoms. Okay, pulmonary symptoms. Okay, along with this pulmonary symptoms, they might have extra pulmonary symptoms also. So they might have extra pulmonary symptoms also. Extra pulmonary symptoms. Extrapulmonary symptoms also. Okay, so what are the extrapulmonary symptoms? The patient might have arthritis. The patient might have arthritis. Okay, then second, the patient might have erythema nodosum. Erythema nodosum. These are the erythema nodosum lesions. Okay, so the presence of erythema nodosum in a patient indicates actually a good prognosis. A sarcoidosis patient with erythema nodosum has relatively a better prognosis than a patient without erythema nodosum. Okay, how these lesions will be? These lesions are red, tender nodules in skin. So when you take a biopsy of this lesion, it will show features of paniculitis. So recently I too had a patient. This patient was treated as post-viral myalgia everywhere, and this lesion was unnoticed, and this turned out to be a acute sarcoidosis. This was seen in a recently in a young patient who was around some 20 years, okay, who had these kind of lesions, okay, and it turned out to be a erythema nodosum, okay, erythema nodosum, okay. Then these patients with acute sarcoidosis can also develop anterior uveitis. So it is also associated with anterior uveitis. So acute sarcoidosis is associated with anterior uveitis. Okay. So here we have two syndromes which are worth knowing, and it is very important for exam also. Okay, exam also. So this two syndromes always tries to confuse me. So I have made a special song for that. Okay, for you people. Okay, early morning. Okay, early morning song for you. Okay, so this song, if you see the song, you can tell me what is the song. So everyone would have seen this song, right? So this song is a funny looking song, okay? And this song is Helena song, okay? So this Helena song, okay, was once a famous song, okay? So that Helena is also related to us, okay? How this Helena is related to us, okay? Whenever you hear this word, then you have to stop the people and say, the question setter and tell that, I know the answer. Okay, so you have to laugh at the examiner who sets this question and tell that I know the answer. So it is Lofgren syndrome, which is associated with acute sarcoidosis. Okay, acute sarcoidosis. Okay, what is that Lofgren syndrome? It is Helena. What is Helena? Hilar adenopathy, where lymph nodes are involved. Okay, lymph nodes are involved. Okay, next, erythema nodosum. Okay, and next is arthritis. Arthritis. So this is symmetrical arthritis, and it involves more commonly ankles. Ankles. How this condition has prognosis? This has an excellent prognosis. This has an excellent prognosis. Okay, so hilar adenopathy, erythema nodosum, and arthritis. So you remember for Lofgren syndrome, it is going to be Helena. Okay, never forget Helena Lofgren syndrome. Okay, Helena Lofgren syndrome. Okay, so you should laugh when you see this Lofgren syndrome and tell that Helena. Okay, so hilar adenopathy, where lymph nodes are getting involved, erythema nodosum is there, and arthritis, which is going to be a symmetrical arthritis involving the ankle, and this has an excellent prognosis. Okay, the next syndrome is Hereford syndrome. What? Hereford syndrome. Okay, so whenever you hear the word Hereford syndrome, your face will go like, what is this? Okay, so what is this? Okay, so for Hereford syndrome, you remember you remember a puff face. Okay, what is that puff face? The puff face has parotitis. Okay, where parotid gland enlargement is there, and it is going to be bilateral parotitis. And these patients will have uveitis. Okay, uveitis, which is going to be an anterior uveitis. Anterior uveitis. And these patients can have fever. And the patients will have bilateral element type of facial nerve palsy. Bilateral element type of facial nerve palsy. So these patients are going to have parotitis, which is going to be bilateral, uveitis, which is going to be an anterior uveitis. Patient is going to have fever and bilateral element type of facial nerve palsy. Okay, element type of facial nerve palsy. This is called as Hereford syndrome. So you have to remember these two syndromes, and you should never forget these two syndromes, which is going to be our Hereford syndrome and Lofgren syndrome. Okay, so you have to always remember this. Okay, next is coming to chronic sarcoidosis. Chronic sarcoidosis. Okay, chronic sarcoidosis. So chronic sarcoidosis is seen in 2/3 of cases. Okay, so already we saw that it is rare for an acute sarcoidosis to develop into a chronic sarcoidosis or to convert into a chronic sarcoidosis. So many times we have an insidious onset and gradually progressive disease, okay, which is going to be chronic sarcoidosis. And the most common presentation of chronic sarcoidosis is going to be lung involvement. Okay, so pulmonary involvement is the most common involvement. Pulmonary involvement most common organ getting involved. Okay, usually the patient will be asymptomatic at early stages. Okay, and then the patient develops interstitial fibrosis. Because of the interstitial fibrosis, what is going to happen? As you people are experts in it, the patient is going to develop cough, which is going to be a dry cough. Okay, and the patient is going to have exertional dyspnea. Okay, and they will have Velcro Krebs like presentation and auscultation. Okay, and this interstitial fibrosis is upper lobe predominant. This is very important point you have to remember, upper lobe predominant. So this has been asked several times in exam, and this upper lobe involvement is a very, very important thing you have to remember. Okay, so always you have to remember that there is no pneumothorax cavity formation or caseation in sarcoidosis. Okay, rarely you can get pleural effusion in less than 5% of cases. Okay, and usually it will be a unilateral pleural effusion. Unilateral pleural effusion. Okay, unilateral pleural effusion. Okay, so the patient is going to have a interstitial fibrosis, okay, and upper lobe predominant. Because of this interstitial fibrosis, the patient is going to have a PFT, pulmonary function test, which shows a restrictive pattern. Okay, and we all know that the patient is going to have hilar lymphadenopathy hilar lymphadenopathy. Because of the hilar lymphadenopathy, there is going to be compression of airways and the patient can develop obstructive pattern also. Compression followed by obstructive lung disease like pattern. Okay, and sarcoidosis is one of the miscellaneous cause for pulmonary hypertension. One of the miscellaneous cause for pulmonary hypertension. Okay, one of the miscellaneous cause for pulmonary hypertension. So these are the manifestations of sarcoidosis in lung. Okay, then coming to lymph node manifestation. Lymph node manifestation. Okay, so these patients, okay, with sarcoidosis can have central lymph node involvement and peripheral lymph node involvement. Okay, peripheral lymph node involvement. Okay, so central, okay, central, it is going to be 90% of cases having hilar or mediastinal lymph nodes. Mediastinal lymph node involvement. Around 40% of cases are going to have axilla or neck lymph node involvement. Neck lymph node involvement. Okay, this peripheral lymph node involvement. This peripheral lymph node involvement is the most frequent extrapulmonary manifestation. Most frequent extrapulmonary manifestation. Most frequent extrapulmonary manifestation. Okay, so this is about the lymph node involvement. Okay, lymph node involvement. Okay, hope you people have copied this. Okay, so next I will go to ocular manifestation. Okay, ocular manifestation. So the ocular manifestation is going to be in the form of iridocyclitis. Okay, where the patient is going to have more commonly anterior uveitis than posterior uveitis. So it is going to be more commonly anterior uveitis. Okay, there can also be keratoconjunctivitis. There can be retinal vasculitis. And the patient can have chorioretinitis. Okay, so these are the ocular manifestation of sarcoidosis. Then coming to skin. Usually a patient with sarcoidosis will have lot of papules like this. Okay, they are called waxy skin papules. Okay, these are called waxy skin papules. Okay, waxy skin papules. So these are the waxy skin papules. You can see here, these are the waxy skin papules. Okay, and these patients can develop a feature called scar sarcoidosis. Okay, scar sarcoidosis. So what is scar sarcoidosis? Scar sarcoidosis is the patient has inflamed purple skin elevation at sites of scar. Okay, so they can give you a clinical picture where the patient had an old trauma, and over the old trauma, the patient developed a nodular picture. What can be the cause? So it can be a scar sarcoidosis. So you can see here, this is a scar sarcoidosis. So the patient has underwent ear piercing, and there the patient has developed a granuloma, and this is called scar sarcoidosis. And this patient has undergone a surgery, and followed by surgery, the patient has developed a nodular lesion all over. Okay, nodular lesion all over, and this is going to be again a scar sarcoidosis. Okay, scar sarcoidosis, and this is one characteristic picture given in all books, and wherever you study sarcoidosis, this picture will never go unnoticed. Okay, so that kind of picture is this one. So anyone can make the diagnosis from the picture? It is called, very good, lupus perineum. It is called lupus perineum. Very, very important point. Okay, lupus perineum. Okay, so this is a chronic inflammatory lesion at ridge of nose and below eyes. Below eyes. Okay, so this shows when you take a biopsy, epithelioid granulomas at the level of dermis in face. Okay, so this is called lupus perineum. Okay, chronic inflammatory lesion. So it is a chronic inflammatory lesion. Okay, at the ridge of the nose and below the eyes, which shows epithelioid granulomas at dermis. Okay, and this is one of my patient who had a. This is one of my patient who had a. Sorry, this is one of my patient who had a lupus perineum. So it is in Westerners, it is so typical. You have a red inflamed lesion. Okay, but here in our setup, we used to get something like a darkening of the skin, which is having a reddish hue. Okay, this is called as lupus perineum. Next manifestation, the most important manifestation where we can have a lot of questions, it is going to be neurosarcoidosis. Neurosarcoidosis. Okay, the most important manifestation of neurosarcoidosis is going to be cranial nerve palsy, where you're going to have 7th cranial nerve involvement, okay, which is going to be element type, which is going to be unilateral or bilateral. Unilateral or bilateral, but it is going to be 7th cranial nerve palsy. Okay, and these patients can also have optic neuropathy. Optic neuropathy. These patients can develop peripheral neuropathy. Neuropathy. Okay, they can develop granulomatous lesion. Involving the brain and spinal cord. Involving the brain and the spinal cord. Okay, and sarcoidosis is one of the important cause for aseptic meningitis. Aseptic meningitis. And there are a lot of cases where sarcoidosis have initial presentation as seizure. Okay, seizure, where they have initial presentation as seizure. Okay, so this is the manifestation of neurosarcoidosis, and it is one of the important topic. Okay, one of the important topic, and the prime importance is being given to 7th cranial nerve palsy. 7th cranial nerve palsy. Okay, then coming to an important thing where the examiners have fun in asking this question every time in exam. Okay, so that is the granulomas has macrophages, and these macrophages have 1-alpha hydroxylase activity. 1-alpha hydroxylase activity. Because of this 1-alpha hydroxylase activity, what is going to happen is 25-hydroxy polycalciferol is converted into 1,25 dihydroxy cholecalciferol. Okay, it is converted into 1,25 dihydroxycholecalciferol. So this results in formation of an active vitamin D3. Okay, this vitamin D3 will result in increased calcium absorption. So already we have seen that whenever the serum calcium increases, what is going to happen? The urine calcium is going to increase. So the patient is going to develop increased urine calcium. Whenever the urine calcium increases, the patient is going to develop renal stones. Renal stones. Okay, and this increased calcium absorption will also result in nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. Okay, it is going to cause nephrogenic diabetes insipidus. Okay, so a patient with sarcoidosis will have increased urine calcium and increased serum calcium. Okay, both will be increased, and this results in nephrocalcinosis and nephrolithiasis, and these patients are also known to develop distal RTA, distal renal tubular acidosis. They are known to develop distal renal tubular acidosis. Okay, distal renal tubular acidosis. So very, very important thing, they can give a clinical scenario where patient has distal RTA with characteristic X-ray features. Okay, so it can be a case of sarcoidosis. Okay, sarcoidosis. Then next is renal manifestation. Renal manifestation. The most common renal manifestation is going to be tubulointerstitial disease. Okay, and the most common glomerulonephritis associated with sarcoidosis is going to be membranous glomerulonephritis. Membranous glomerulonephritis. And the most common cause of renal failure is going to be hypercalcemia itself. Hypercalcemia. So these three important points you have to remember. The most common renal manifestation is going to be tubulointerstitial disease pattern, and the most common glomerulonephritis is going to be membranous glomerulonephritis, and the most common cause of renal failure is going to be hypercalcemia. Hypercalcemia. Okay, next is pituitary involvement. Pituitary involvement. Okay, these patients with sarcoidosis will have posterior pituitary infiltration. Posterior pituitary infiltration. Posterior pituitary infiltration. And this posterior pituitary infiltration will result in diabetes insipidus. So it is going to cause, sarcoidosis is going to cause both central and nephrogenic diabetes insipidus. Okay, the mechanism is different. Okay, the mechanism is different. Okay, so the diabetes insipidus mechanism is going to be different, but it can cause both central and nephrogenic diabetes insipidus. Next is musculoskeletal involvement. Okay, musculoskeletal involvement. Okay, so this is a funny fancy name we have here. Okay, these patients will have a special chronic form of sarcoidosis where there is going to be osteolysis with cystic changes in the bone. Cystic changes in bone. So anyone can tell me what is the name of this disease? Where in sarcoidosis there is going to be osteolysis with cystic changes in the bone. Okay, this is called as Perthes jungling disease. Perthes jungling disease. Perthes jungling disease. Okay, where the patient is going to have in the fingers, especially in the fingers, they are going to have cystic changes with osteolysis like this. You can see here, there is going to be cystic changes present here. You can see the cystic changes present here. Okay, and you can also see the osteolysis here. Osteolysis here. Okay, I think you can appreciate this very well. See here, this is the osteolysis, and you can also see the cystic changes here. Cystic changes here. This is called as Perthes jungling disease. Okay, Perthes jungling disease. I'll show you another picture. This is also indicates Perthes jungling disease, where the patient is going to have a lot of areas of osteolysis. You can see the areas of osteolysis here. Okay, at the same time, you can see a lot of cystic changes here. Okay, this is called as Perthes jungling disease. Okay, Perthes jungling disease. Perthes jungling disease. Okay, then these patients can also have psychiatric manifestations. Okay, psychiatric manifestations. So, what are the psychiatric manifestations? Okay, what are the psychiatric manifestations? Okay, so there is some kind of interruption. So it's a month of Margari in Tamil Nadu. So temples nearby start their prayers in the early morning. So there is some kind of sounds. Okay, okay. So leaving apart the things of disturbance which disturbs us and our preparation, we have to go ahead whatever comes in our way. Okay, so what are the psychiatric manifestation? The patient can have a depression, pain, chronic pain, and fatigue. So the psychiatric manifestations can be the form of depression, pain, and chronic fatigue. Okay, chronic fatigue. Okay, so these are the psychiatric manifestations. What are the miscellaneous or other manifestations of sarcoidosis? Okay, these patients are going to develop granulomatous, hepatitis, intrahepatic cholestasis, bone marrow granuloma. Okay, so this is the liver manifestation, and because of this, the patient can have an increased alkaline phosphatase. Okay, these patients can develop bone marrow granuloma. Okay, then patient can have anemia, lymphopenia, and hypogammaglobulinemia. Hypogammaglobulinemia. Okay, so these are the blood manifestations. Okay, then the last is going to be cardiac manifestation. Okay, these granulomas will tend to occur over the left ventricular wall more commonly. Left ventricular free wall more commonly, like this. Okay, these granulomas can occur. Okay, and it can also occur over the septum. It can also occur over the septum. Okay, but left ventricular free wall is more commonly getting involved. Okay, and these patients, because of the granulomas, they can develop heart blocks, valvular heart diseases, and because of the interruption of the conduction system, the patient can develop arrhythmias, okay, and cardiomyopathy. This cardiomyopathy can be of both dilated cardiomyopathy type and restrictive cardiomyopathy type. Restrictive cardiomyopathy type. Okay, restrictive cardiomyopathy type. So whenever a patient with respiratory symptom is coming to you, what you are going to do? You are going to do a chest X-ray. Okay, you are going to do a chest X-ray. So when you do a chest X-ray, you are going to get a hilar lymphadenopathy. You are going to get a hilar lymphadenopathy. Okay, hilar lymphadenopathy. And you can also get bilateral upper lobe infiltration. Bilateral upper lobe infiltration. So these patients, when you take an X-ray, the X-ray will be like this. So this will be the X-ray where the patient is going to have hilar lymph node enlargement, okay, like this, where the patient has one lymph node here, one lymph node here, and one lymph node here. Okay, one lymph node here, one lymph node here, and one lymph node here. And this is going to look like putting number 1, 2, 3. So this is also called as 1, 2, 3 sign. 1, 2, 3 sign. Okay, 1, 2, 3 sign. Okay, and this is also looks like an inverted garland. Okay, it looks like a garland. The old marriages, in 90s marriages and 80s marriages, you will have a garland like this. Here there will be one design, here there will be one design, and here there will be one design. One small round patches will be kept. Okay, if you take the old garlands, okay, marriage garlands, okay, that kind of appearance will be there. So this is called as garland sign. Okay, or if you go to UK, okay, you can have this pawnbrokers. Okay, pawnbrokers will have a symbol indicating that they are pawnbrokers to attract people. Okay, they will have 3 balls like this. So you will also have a 3-ball picture here in the X-ray. So it is called as pawnbroker sign or pawn ball sign. Okay, you're going to get a pawn ball sign. So you get a garland sign, pawn ball sign, or 1, 2, 3 sign. Okay, the hilar lymphadenopathy pattern is going to be the 1, 2, 3 sign. Okay, 1, 2, 3 sign. Okay, then you can do a lateral X-ray. Okay, you can do a lateral X-ray. Okay, lateral X-ray, and if you see here, there is a large lymph node enlargement. Okay, so it looks like a cauliflower like mass. Okay, it looks like a cauliflower like mass, a irregular mass. It looks like a cauliflower like mass. So you get to see a cauliflower like hilar lymph node enlargement. Cauliflower like hilar lymph node enlargement. Okay, so this is going to be again telling you that the patient is having hilar lymphadenopathy. Okay, hilar lymphadenopathy. Okay, so this is also an important view where you can say the patient has a hilar lymphadenopathy. So this patient with sarcoidosis, the X-ray can be used as a scoring system, and this is called as scadding scoring system. Scadding, staging, or scadding scoring system. Okay, what is this scadding staging? Okay, so now what you do is you are going to take a chest X-ray of the patient. Chest X-ray of the patient. In stage 1, okay, stage 1, you are going to have only hilar lymphadenopathy. Hilar lymphadenopathy. Okay, so there is going to be one hilar lymphadenopathy only. Okay, then stage 2. Stage 2. The patient is going to have hilar lymphadenopathy. Along with hilar lymphadenopathy, the patient is going to have also infiltrates. Okay, the patient is going to have infiltrates in the chest. 2 is both. So I remember 2 is both. Second alphabet B, so both. So it is going to have hilar lymph node and infiltration in the lung. Okay, infiltrates in the lung. Then it is going to be stage 3, where I am going to do a chest X-ray. The chest X-ray shows only infiltration. The chest X-ray shows only infiltration. Infiltration. Okay, so it is going to be infiltrates alone. Okay, then I go to stage 4. Stage 4. Stage 4. If I do a chest X-ray, the chest X-ray is going to show areas of fibrosis. Okay, the chest X-ray is going to show areas of fibrosis like this. Areas of fibrosis. Okay, so it is going to show areas of fibrosis. So this is called as scattering staging of sarcoidosis. Okay, scattering staging of sarcoidosis. So this is, again, you can see here hilar lymph node alone. Here there is going to be stage 2 where hilar lymphadenopathy with the chest infiltration, and here infiltrates alone, and here there is going to be having fibrosis. Okay, this is called as scattering staging. Okay, scattering staging. What is the best investigation? The best investigation is going to be HRCT. The best investigation is going to be HRCT. Okay, this HRCT is going to show peribronchial and perilymphatic thickening. Peribronchial and perilymphatic thickening, especially in the subpleural area. Subpleural area. So this is what, see here, there is going to be peribronchial, okay, and perilymphatic thickening. You can see the thickening here. You can very well appreciate the thickening here, okay, and you can also see the thickening, peribronchial thickening here, lymphatic infiltration here, and you can also see the thickening along the areas of pleura, okay, along the areas of pleura, and here also you can see the peribronchial thickening, okay, peribronchial thickening, okay, and whenever in a CT scan you have an adenopathy, okay, of more than 2 centimeter, okay, it favors sarcoidosis over other interstitial lung diseases. So whenever you have a hilar lymphadenopathy of more than 2 centimeter in a CT scan, it favors the sarcoidosis as the diagnosis. Favors sarcoidosis as the diagnosis. Okay, so adenopathy of more than 2 centimeter is significant. Okay, then next is you get to see in CT scan, whenever the subpleural area is getting involved, you will get a galaxy-like appearance. Okay, so in a CT scan, you will get a galaxy-like appearance. Okay, like this, galaxy-like appearance. Okay, you can see these two things are almost looking similar, this one and this one. So this is called as galaxy sign, where subpleural involvement is seen like a galaxy, okay, galaxy. Then next is you are going to do DLCO. We know that this is going to be interstitial lung disease. What is going to happen to the DLCO? DLCO will be reduced. Okay, then you can go for bronchoalveolar lavage. Okay, again, this is very important for your exam, where you will get to see lymphocytes, where you are going to check for CD4 CD8 ratio, and it is more than 3.5, then it is sarcoidosis. few books gives more than 4, few books gives more than 3.5. You can remember both. Okay, so it is indicating sarcoidosis. Okay, sarcoidosis. Okay, so higher amount of lymphocytes are seen with CD4-CD8 count ratio more than 3.5. Okay, what is the gold standard investigation? The gold standard investigation is going to be biopsy. Okay, biopsy, where you are going to get to see a non-caseated, well-defined granulomas. So already we have seen this. Okay, and it is mandatory to do a biopsy to make a diagnosis of sarcoidosis. Okay, so we have to do a biopsy to prove that this is sarcoidosis. So the gold standard is going to be biopsy. Okay, biopsy. Okay, so what you can do, you can do a PET scan. So this PET scan will tell which lymph node has to be biopsied. Okay, the PET scan will tell which lymph node has to be biopsied to be selected. And then what we can do, we can go for an EBUS, endoscopic bronchial ultrasound, and then we can go for biopsy. Endoscopic bronchial ultrasound and then do a biopsy. So what we are going to do, we are going to do a PET scan and we are going to locate which lymph node has to be selected. So if this lymph node is going to be selected, then what we are going to do, we are going to do an endoscopic bronchial ultrasound and we are going to select the lymph node and then we are going to go for the biopsy of the lymph node. You can see here, this is how the biopsy is being done. Okay, so this is also going to show you an EBUS. Through the EBUS, you're going to put the needle and take the biopsy. Okay, biopsy. When you do a biopsy, what you're going to see here, this is a purple color epithelioid cells. Okay, purple color epithelioid cells. So this is a granuloma and we are going to have the epithelioid cells here. Okay, epithelioid cells here. Epithelioid cells here. Okay, epithelioid cells here. And this is also a non-caseating granuloma. You can see a big non-caseating granuloma. Okay, big non-caseating granuloma. Okay, there are multiple non-caseating granulomas which coalesce to form a single non-caseating granuloma. Okay, and a patient with the sarcoidosis have certain characteristic named bodies in the biopsy. So okay, so we will see what is it. And whenever you have a patient who is asymptomatic, okay, but bilateral hilar lymph nodes are there, asymptomatic but bilateral hilar lymph nodes are there, okay, then patient has Lofgren syndrome and patient has Hereford syndrome. Here, actually biopsy is not required as the clinical feature or these features itself is more than enough to tell the diagnosis as patient is having sarcoidosis. So Lofgren syndrome, Hereford syndrome, the features present itself is going to tell that this patient is having sarcoidosis. So there is no need for biopsy. Okay, so you do a biopsy and in biopsy you get to see calcium and protein inclusions inside Langhans cells like this. Okay, like this. Okay, these are called as Schaumann bodies. These are more specific for than other findings. These are more specific for sarcoidosis. More specific for sarcoidosis. Then you get to see star-like bodies here. Okay, star-like bodies here, which are PAS positive and eosinophilic PAS positive and eosinophilic star-like bodies called as asteroid bodies. Okay, they're called as asteroid bodies. Asteroid bodies. Okay, they're called as asteroid bodies. Then next feature is going to be like this. Okay, so they are hemoffusion containing lysosomes. Hemoffusion containing lysosomes. Okay, hemoffusion containing lysosomes, and these are called as, okay, Hamasaki. I will write here, Hamasaki Wesenberg bodies. Wesenberg bodies. Okay, so with this, we will go directly into the investigation, which is going to be 67 gallium scan. Okay, where there is increased uptake in lacrimal and parotid gland and hilar lymph node, and this is going to give a lambda sign and a panda sign. So this is going to give a lambda and a panda sign. Lambda and panda sign. Okay, this is the lambda sign and panda sign. Okay, and in these patients with sarcoidosis, we all know that serum AC level is increased. Serum AC level increased, and the granuloma itself will secrete the ACE. Granulomas itself will secrete ACE, and these patients will have Mantoux test negative. So it is a non-caseating granuloma, okay, or a granulomatous inflammation where it is Mantoux test negative, and Kivim's test is an older test which is positive. What is Kivim's test? Kivim's test is you are going to inject spleen extracts of a sarcoid patient, okay, and you are going to read after 4 to 6 weeks. 4 to 6 weeks later, you are going to read it, and if you get a granuloma like this, then it is called as Kivim's test positive. But nowadays this test is not being done. Okay, not done. Okay, so what is the treatment? No treatment if patient is asymptomatic. Okay, patient is having acute manifestations like Lofgren or Hereford because they are self-resolving, or isolated bilateral lymph node, hilar lymphadenopathy. There is no need for treatment. Okay, you go for steroids as treatment if patient has optic neuritis, uveitis, CNS manifestation, and grade 3, 4 or stage 3, stage 4 lung disease. Okay, and you will start on prednisolone and you will taper over a period of 2 to 3 months. Taper over a period of 2 to 3 months. Okay, if steroids is not working, if the patient is refractory to steroids, then what you can do is the second drug of choice is going to be methotrexate. Methotrexate. Apart from methotrexate, you can try azathioprine, okay, and infliximab. But steroids followed by methotrexate. If patient is not responding to anything, then you go for lung transplantation. Lung transplantation. Okay, so this is how you will treat a patient with sarcoidosis. Okay, so this is about the treatment of sarcoidosis, and I want to tell up one extra point here. Okay, so extra point here. This is latest markers which can be used in sarcoidosis. They have not been 100% foolproof method to tell that patient has sarcoidosis. These are newer markers. So the newer markers are serum amyloid A soluble IL-2 receptor, okay, and neopterin. And these two correlates with disease activity. So they are newer markers. They can ask if at all they're going to ask newer markers in INICET kind of exam. Okay, INICET kind of exam. So with this, we have broadly covered sarcoidosis. I think this is more than enough for you to know about sarcoidosis, and this will be more than enough for your exams also. Okay, so we will see a few questions and then we can finish the session. Okay, so the question is, the most common pulmonary manifestation of mechanism of pulmonary hypertension in sarcoidosis. The most common mechanism for pulmonary hypertension in sarcoidosis is. Okay. So even though there is going to be a granulomatous inflammation, but ultimately if you see pulmonary hypertension pathology is fibrosis, okay, fibrosis. So pulmonary hypertension pathology, in pulmonary hypertension, we have seen that there is going to be fibrosis of the vessels, okay. So the fibrosis of the vessels will ultimately result in obliteration. There is going to be granulomatous infiltration, which is going to cause fibrosis of the vessel that results in pulmonary hypertension. So here the better answer is going to be A. Okay, even though granulomatous infiltration occurs, but ultimate pathology in pulmonary hypertension is going to be fibrosis of the vessel. If you go and recollect from our pulmonary hypertension thing, you can easily remember that there is going to be fibrosis of the pulmonary vessels. Okay, fibrosis of the pulmonary vessel. Next question. Which of the following is typically unilateral in sarcoidosis? Which of the following is typically unilateral in sarcoidosis? So, what is the answer? What is the answer? Which of the following is typically unilateral in sarcoidosis? It's going to be pleural effusion. Very good, pleural effusion. Okay, pleural effusion. Then next, which of the following observation helps to differentiate neurosarcoidosis from multiple sclerosis? Neurosarcoidosis from multiple sclerosis. So these are atypical questions, okay? So, but it's a very good thought-provoking type of questions, okay? Very good thought-provoking type of questions, okay? So, if you recollect multiple sclerosis, okay, where multiple sclerosis, there is going to be demyelination, okay, involving the tracts, okay, and we know the 4 areas where in MRI commonly we get involvement of multiple sclerosis, okay, and the periventricular dorsal fingers also, you know, okay. So in neurosarcoidosis, we know that there is going to be aseptic meningitis, so there is going to be meningeal enhancement. Hypothalamic involvement is not seen in multiple sclerosis, but here we get to see diabetes insipidus. Then pulmonary and skin involvement are characteristic. So I prefer answer D as the answer. Okay, I prefer D as the answer. So how these questions have to be solved is you have to put all your concepts together. So we didn't see these things separately. So all these concepts have to be correlated when you make a diagnosis for these kind of questions. Okay, the most common location of sarcoid granulomas and scars in the heart. So everyone is sure that the answer is C. It is more commonly tend to involve the left ventricular free walls, and the answer is left ventricular free wall. Okay, by chest radiograph, sarcoidosis stage 3 refers to which of the following? So we know that A is hilar lymph node, or stage 1 is hilar lymph node. Okay, 2 is both, 3 is infiltration, 4 is fibrosis. Okay, so the answer is going to be C. Very good attempt by every one of you. Okay, the next question. Okay, this one will go. In BAL, CD4-CD8 ratio of more than which of the following is strongly supportive of sarcoidosis? Very good. The answer is more than 3.5. More than 3.5. Very good. Okay, very good attempt. The next question is, okay. Bilateral hilar lymphadenopathy, ankle arthritis, and erythema nodosum in sarcoidosis is called as. So what you remember here, who comes to your mind? Helena will come to your mind. So the answer is going to be Lofgren syndrome. What is Kaplan syndrome? We'll just recollect what is Kaplan syndrome. What is Kaplan syndrome? What is Kaplan syndrome? Kaplan syndrome is rheumatoid arthritis with pneumoconiosis and pulmonary infiltration. Right? Then what is Sneddon syndrome? What is Sneddon syndrome? Sneddon syndrome. Recollect rheumatology class. After SLE, what we discussed? There we discussed Sneddon syndrome. Yes, after APLA, in APLA, what we saw? This is livido racemosa reticularis with CVA. Okay, CVA. Okay, is called in a patient with APLA is called as Sneddon syndrome. What is Lyric syndrome? Lyric syndrome. Surgery class. It is going to be aortoiliac occlusive disease. Okay, occlusive disease. Okay, occlusive disease. This pulmonary infiltration is in the form of nodules. Okay, so aortoiliac occlusive disease. So answer here is going to be Lofgren syndrome. Okay, Lofgren syndrome. Then answer for this. So very good. So this patient has loss of weight, dyspnea on exertion, night sweats, and there is a painless lesion over the nose. So lupus perineum is there, and chest X-ray shows hilar lymphadenopathy. So 1, 2, 3 sign is seen. Okay, so this is a case of sarcoidosis. Okay, this is a case of sarcoidosis. Very good attempt. Okay, very good attempt. Okay, so next question is this one. So we'll check your observation capacity in the early morning hours. How well you have observed. Easy question. Clinical pathological question. So it is the appropriate answer is here is going to be there is going to be a T helper cell mediated interferon gamma production, which is going to result in formation of a granuloma. Okay, which is going to result in a formation of a granuloma. Very good. Okay, so the next question is okay. Again, this is a thought-provoking question. So I have put this question because I want you to think and answer. Yes, the recent improvement in the answer poll is going to be the answer. Very good thought. Very good thought. So these people have to win the race. The 4 lines are running. Which line is going to win? So here majority have told that none. Okay, so that is the answer. Okay, actually E is not there actually, but this is going to be the answer because I told you that whenever a patient has a hilar lymphadenopathy, a rash, fever, and arthritis, what is the diagnosis? What is the diagnosis? It's going to be, the diagnosis is going to be acute condition. What is the diagnosis? It is going to be, it's going to be a patient having Lofgren syndrome. Okay, Lofgren syndrome. Okay, whenever a patient has a Lofgren syndrome, okay, along with the patient has erythema nodosum like feature, it is acute condition where there is no requirement for treatment as such, and these features itself tell the diagnosis is going to be sarcoidosis. So there is going to be no need for further investigations to confirm the diagnosis as such. Okay, so as such there is no further need of any investigation. Okay, so we'll finish with 2 more questions. Okay, 2 more questions. Just spare 5 minutes with me. Okay, so lung involvement in pulmonary sarcoidosis is most commonly described in which of the following? Answer is very good. They are going to be peribronchovascular and perilymphatic nodules in the subpleural region. Okay, so the answer is A. Very good attempt. Very good. Okay, then we'll finish with this question. Okay. Okay, we finished two more questions. So here the answer is going to be hypercalcemia because of 1-alpha hydroxylase activity, and this is going to be the answer. And we know that AC level is increased, hypervitaminosis D will be there, and ADH will be decreased, and this is not okay. So the answer is going to be hypercalcemia. Okay, hypercalcemia. Okay, so last but before question, okay, spare few seconds with me. That will be more than enough. Okay, that will be more than enough. The 32-year-old female, uveitis, cough, arthralgias in the ankles and legs, elevated ACE, skin PPD, that is MAN2 negative, FE1 by FEC upon spirometry is increased or normal. Which of the following you would be expecting on the chest X-ray? So the diagnosis is going to be sarcoidosis, and sarcoidosis means you have to go in, you have to expect for the enlarged hilar lymph nodes. Very good. Okay, the answer is enlarged hilar lymph nodes. Okay, last question of the morning session. Okay, this is going to be the last session. So you have to tell me what is the answer. A 31-year-old African American female presents with painful shin nodules, uveitis, and calcified hilar lymph nodes. The transbronchial biopsy, if it was done for this patient, which of the following histology it will show? So the finding, okay, the finding in biopsy is going to be non-caseating granuloma. Okay, if there is a non-caseating granuloma, then your diagnosis is going to be sarcoidosis. Okay, so non-caseating granulomas are the finding in sarcoidosis patients. Okay, so the answer is going to be non-caseating granulomas. Even though subpleural region is the most common region of involvement, but it is not cyst formation or any acute inflammatory changes. It is going to be a non-caseating granuloma. So the answer is non-caseating granulomas. So with this, we will finish our today's discussion. Hope you enjoyed the session. Okay, so we had a brief discussion. Okay, and more than enough discussion about sarcoidosis, and it will be very helpful for your preparation. So try to solve the questions. Okay, and we will meet in some other session in the coming week, and I will try to send you the PDF. Okay, I will send you the PDF. Okay, if any doubt, you can let me know. Okay, all the very best. Study well. Okay, and do well. Okay, thank you all.